Atypical nevi are important, but they're so often misunderstood. A bit like me, really. In this video, we'll be exploring what they are, why they matter, and it's not what you think, and what to do when you find one on your patient in primary care. What is an atypical nevus? To explain that, we need the help of a cat. Bear with me here, because it's like this. In 1935, physicist Erwin Schrödinger did a thought experiment to illustrate a dilemma in quantum physics. Let's recreate his experiment. You put your cat in a box, and then you add a radioactive atom with a 50-50 chance of decaying. There's a sensor to detect if that atom has decayed or not, and a vial of poison which is released into the box if the atom's decay is detected. Something tells me Owen didn't like cats. Don't worry, it's only lidocaine. Please don't call Animal Welfare Services. So, is our cat in the box alive or dead? It could be in either state, and the only way to know is to observe it by opening the box. To Owen, this showed the problem of quantum mechanics, where it states an atom can be in two different forms at the same time until it is observed. This is exactly the same problem we face with an atypical nevus on our patient's skin. It could be one of two things. Either it's a benign nevus that just happens to look odd, or a melanoma. The only way to know is to open the box and observe it. How do we open the box holding an atypical nevus? You cut it out and let the pathologist decide. And many clinicians take this approach. If in doubt, cut it out. Because to miss a melanoma can be disastrous to your patient. Right, that's it then. Let's cut out every atypical funny looking mole just to make sure it's not a melanoma. Whoa, are you sure you really want to do that? Consider this, around 10% of people with lighter skin types have at least one funny looking mole. That's an awful lot of putting holes in your patients, just to be sure. Aha, you may say, surely an atypical ugly looking mole, even if it isn't a melanoma now, has an increased chance of turning into a melanoma. Therefore, cutting it out will reduce your patient's risk of developing one. That seems a logical conclusion, but unfortunately it's wrong, and for this reason. Studies have shown that the chances of an atypical benign nevus turning into a melanoma is around 1 in 35,000 a year. That's an awful lot of atypical benign nevi to remove to prevent one melanoma. Remember, the vast majority of melanomas don't start within a nevus of any kind. Therefore, removing a patient's atypical nevus doesn't reduce your patient's future risk of developing a melanoma in any meaningful way. You know what? I feel a diagram coming on. Here's our typical common benign mole or nevus, and if you don't know their life story, why we get them, and how they naturally change or disappear over time, you need to watch this video. They are ABCD negative, and if you don't know what the ABCDE signs are, then you need to watch also this video here about melanomas. You'll recognize an atypical nevus because it has at least one or more of the ABCD signs. There are other names people use for atypical nevi. I don't like the term dysplastic because you can only really tell if the cells are abnormal, i.e. dysplastic, under a microscope. To patients, I call them funny looking moles because they are, unless they are a melanoma. The truth is, telling the difference between an atypical nevus and an early melanoma is one of the hardest things to do in dermoscopy. I've got it wrong in the past, and I will show you that patient later so you can learn from my mistakes and you can judge me. But if you are just starting out in dermoscopy, my advice is this: refer them all. For a second opinion, keeping photographs, learning from the feedback from secondary care. Focus your learning initially on being confident in identifying everything else. What I want to do for you now, however, is teach you how you can look inside that Schrödinger or atypical nevus box without lifting that lid. We can shake the box in various ways to see what state our cat is, atypical nevus is. I'm going to share with you now the approach I take and the 5 tips to help you do the same. Tip number 5 is the most important. Imagine a patient with a skin lesion. Most often at the end of a consultation with the old patient trick, "While I'm here, doc, can you please just quickly tell me if this mole is okay?" 9 times out of 10, it's not actually a mole. It's usually a seborrheic keratosis. That's one reason why you need to be good at recognizing them. You can reassure your patient, continue on your day, only 30 seconds lost, and your patient will leave your room very happy. What if you look at it, perhaps using your dermoscope, and decide it's a nevus? Well, the life story of a nevus is that they naturally change slowly over time or disappear. The one I most commonly see is a long-standing mole turning into either a raised compound nevus or a wobble sign positive intradermal nevus. This is normal, and the patient can be reassured it's not a sign of cancer. Just now and then, however, it is an odd-looking atypical mole. Box shaking tip 1. See this lady who has already an atypical nevus that was removed, and looking around she has another one that's a little bit misshapen and irregular. On dermoscopy you can see the reason why it's an odd shape. There's a hair follicle causing a pale notch, but the pigment network otherwise is very reassuring. Box shaping tip 1. Use your dermoscope to confirm if it's a misshapen but otherwise normal benign nevus pattern. Box shaking tip 2. This 73-year-old had a BCC on his back, and I was about to remove it in surgery, and then I noticed this nearby. Sorry, the photo's a bit blurry. If it's a nevus, it's atypical. It's asymmetrical. The board is irregular. It's got 2 colours, pink and tan colour. It's 7 millimetres in diameter, so it has a full ABCD of concerns. We just don't know about growth because he didn't know it was there. Here's the dermoscopic photograph. Is it of melanocytic origin? Well, yes it is. There's no aggregate pigmented globules and dots, but we have a pigment network. Not only that, the pigment network is atypical. Normal looking here, but otherwise the lines are thicker and there are holes of various size. It's a bit pink. Could this be a bit of regression? I discussed it with him and he allowed me to cut it out. Opening the box, it was just a dysplastic nevus and not a melanoma. Box shaking tip 2 is this. Is there any growth? Melanomas are growing and changing in a way that benign moles don't. A problem arises when, as with this patient, it's unclear. Box shaking tip 3. We've mentioned in tip 1 how recognising normal nevi dermoscopic patterns can help reassure us that this is just a misshapen atypical nevus and not a melanoma. But are there any melanoma-specific dermoscopic signs that are more likely in a melanoma that would make you want to open that box and see the histology? Well, yes, there are. Studies showed that these are more common in melanomas than in a benign atypical nevus. If you see any of these, your concern should be raised. But it's not a fixed rule. I mean, look at this 63-year-old lady with a new mole on her left thigh. She'd noticed it for around 12 months previously, and it was only 3 millimetres in diameter and flat to touch. Is it a nevus, first of all? It's so small and it's slightly asymmetric with an irregular border perhaps. What does the dermoscopy tell us? It has tan-coloured aggregated globules, so it is a nevus. But note the various sizes and colours of these globules and dots. And being at the edges, that suggests a growing nevus. This is very unusual in a benign nevus. And 1 in 3 to 1 in 4 new nevi in a person over 60 is a melanoma. So despite its small size and it's a 12-month history, it's a concern for melanoma. I referred her on the cancer care pathway and it was excised and, drumroll, it was a severely dysplastic nevus. It needed removing because it could have been a melanoma because of those signs, and it just shows you how dermoscopy can help you make those management decisions. Box shaking tip number 3, look for melanoma specific dermoscopic findings. The more you find, the more concern you should have and a desire to open that box. Box shaking tip 4 is illustrated by this lady. She presented with a nevus which is atypical and the story was unclear about how long it had been there. She's over 60, so if it's confirmed to be a nevus on dermoscopy, I'm already reaching for my open the box referral button. It's got a pigment network, so it is a nevus and it's regular, I think. But what about this bluish central bit? Is this melanin in the dermis and therefore a melanoma? However, doing a skin survey, I found another 2 nevi with a similar dermoscopic pattern such as this one, as well as a few typical reticular nevi such as this. Is she developing a few melanomas all at the same time, or is this just her signature type? Here's the histology report when that box was opened, and it was a benign nevus. She obviously creates nevi with a superficial blue nevus component. My tip 4 is do a skin survey and identify their signature type of mole. If they have many other nevi that look the same, this is reassuring. While it's possible to get 2 or more melanomas at the same time, it's about as rare as a cat obeying the word no. And finally, tip 5, for which you need to step back and put down your dermoscope. It will also explain the true importance of atypical nevi and is best illustrated by a patient. This 51-year-old gentleman came to see me with this mole on his left outer thigh. It had been slowly growing for 2 years. He'd had no previous skin cancers. If it's a nevus, it's atypical. Let's score it A, B, C, D, E. It's asymmetric with a slightly raised pink area here. The border I think is regular though. 2 colours, pink and tan. Diameter was 10 by 15 millimetres. Here's the dermoscopy. I thought, I don't know. Note it's got hairs growing out of it. That doesn't mean much. There's no network pattern. Are these aggregated globules or not? There's some dot vessels and tan and pink colours. What is it? I wasn't sure. I then sat back and recognised that he had an awful lot of moles. I started counting and he had around 100 or more moles and another atypical nevus. I then asked a key question. Has anyone else in your family had a melanoma? Yes, his mum had. I referred him on the cancer care pathway and on excision this was an in situ melanoma. I presented this gentleman at one of our clinical practice meetings and a colleague said, how did you know it was a melanoma? And the thing is, you see, I didn't. The dermoscopy wasn't clear, which should always give you pause for thought, but what really helped clarify my management was doing a little bit of math. My math went like this. He's got white skin, so his average lifetime risk of a melanoma is around 1 in 40. A first degree relative with a melanoma doubles that risk. He's got 80 to 100 nevi. Again, that affects his risk. And he had a couple of atypical nevi. So I estimated his lifetime risk of a melanoma at around 1 in 2 or 50-50. He has what I like to call atypical nevus syndrome, or more properly FAMMM. I don't know about you, but family atypical multiple mole melanoma is just a tongue twister and it's too long to remember. Look out for these patients because prospective studies show that they have a lifetime risk of developing a melanoma of around 50% in those aged 10 to 50 and 82% if they're over 72 years. They have a genetic predisposition to melanomas, and atypical nevi are the key to give you the diagnosis. These people need careful counselling, sun protection, training in self-skin monitoring and regular photographic monitoring of their moles. I found 3 patients who fit this criteria and all are now under secondary care with monitoring, including this chap. Box shaking tip number 5, calculate your patient's lifetime risk of melanoma. What if you think a mildly atypical nevus isn't a melanoma? Could we just monitor it rather than cut it out or refer our patient on? Well, yes we can, and I often do. However, there are important pitfalls to avoid, and I'm now going to show you how I got it wrong in one patient and how I saved the day. The 68-year-old's daughter noticed this mole on her mother's back. It had been there perhaps 12 months, and eventually she persuaded her to come and see us to get it checked out. The daughter had had a melanoma herself in the past. It was only around 6 millimeters, flat and 2 colours and perhaps slightly asymmetric and slightly irregular. Here's the dermoscopy. Note the pigment network pattern. So it is a nevus and there's a few aggregated globules centrally, but not a great variety of colour. A retrospectoscope is a wonderful tool, and looking back, I had enough for a care pathway referral at that initial consultation. However, I decided to monitor due to its small size, the fact it was flat, and I wasn't convinced it was a melanoma. A monitoring interval for such an atypical nevus is 3 months, but for various reasons, hers and mine, it was 6 months before I saw her again. This is what I found. It's now 8 or more millimeters. And what melanoma specific signs can you now see on dermoscopy? The network pattern may be a bit more atypical here, but atypical dots and globules are much more evident, varying in size and colour. We now also have some shiny white structures on polarised dermoscopy and more blue-grey pigment, suggesting maybe there's melanin in the papillary dermis. At this point, I silently cursed myself. It's pointing much more now to a melanoma with the growth and these changes. And on an excision, it was a 0.6mm Breslow thickness melanoma. Having failed to refer her initially, it was my robust follow-up system that saved the day. So when you feel you'd like to monitor an atypical nevus, these are my 4 golden rules for you to consider to follow. 1. The higher the risk of melanoma in that patient, the less willing you should be to monitor an atypical nevus. 2. Never monitor a changing or a new atypical nevus. 3. Never monitor a raised, palpable atypical nevus, because if it is a melanoma, then it may already be undergoing a vertical growth phase, and delaying will worsen your patient's prognosis. Only monitor flat lesions. 4. Make sure you have a foolproof system of follow-up in place, usually initially after 3 months, but monitor as long as you need so you're happy it is stable and it's not growing. I hope this has helped you understand a little bit more about the Schrödinger cat-like nature of atypical nevi and how you can manage them safely in primary care. Why not keep learning by watching this video next here. Training a primary care dermoscopist for every general practice.